You have a good crowd. Appreciate being here. We're going to talk, I guess this is grand rounds for CME. I'm Dr. Zarnecki, Mike Zarnecki. We've got a group of physicians, nurses, case managers, everything like that here. Is that right? And then, any pulmonologists here? Any breathing, respiratory techs? Anyone like that? Okay. Any nurse practitioners or PAs? Physician assistants? Okay. Good, thank you. Well, welcome. This is a pretty nice setup. I've never been down here before. I used to work at a St. Vincent's Hospital in Portland, Oregon a long time ago when I did residency. And then I did all my training out in Houston, Texas at the Texas Medical Center. Anyone from Texas? Oh my gosh, we're in the woods, Alabama over here, aren't we? So I did all my training at the world's largest medical center, the Texas Medical Center, Houston, Texas. It was basically Baylor College of Medicine, where I did all my fellowship training. MD Anderson, Methodist Hospital, at the time St. Luke's Hospital, and they Dr. Denton Cooley, famous heart surgeon. The DeBakey VA is also there. Dr. DeBakey, who I had opportunity to take care of when he was in his final passing years, did the mechanical heart transplants. And then fell in love with pulmonary critical care medicine, and in Houston, working at the DeBakey VA, which at the time was the largest VA in the world. I think it still is, I don't know. Someone was telling me the other day that there's a VA in DC that's a little bit bigger now. But overall, there's about, at that location, there's about 50,000 hospital beds. So for about 6 years of my life, it was pretty miserable as a fellow, because I felt at times we took care of all those patients in all those beds. Then prior to that, I was in the military. I was active duty Air Force, and make a long story short, we were explosive engineer, putting warheads on foreheads was my whole original career, and then fell in love with medicine as a result of doing some work with the troops, and then became a paramedic, and then wind up going to medical school. But at the VA in Houston, Texas, we had and doing my pulmonary training, we had a fantastic pharmaceutical rep. And at those times, they could bring us pens and pads and all those things. And they were talking about this condition of COPD, chronic obstructive pulmonary disease, a genetic form of it called Alpha1 Antitrypsin. And we were like, oh, there's no genetic form of COPD. What are you talking about? And they encouraged us through this testing program to take a closer look at it, and would we test some of the vets? Well, most of our vets were, they had 2 alveoli left, one on the right, one on the left. Right? In the 5 packs a day, 6-pack a day cigarette smoking. Anyone try to smoke 5 packs of cigarettes a day? It's basically a continuous cigarette the whole time. So they had their FEV1s, which is a measurement of your spirometry and how well you can get air in and out, was always below 30%. So we had this testing kit, the test for this genetic condition of COPD, and sure enough, we started finding out a lot of our vets had these genetic markers that would accelerate or cause their COPD condition from cigarette smoking to even be worsened. And so by the time we ended that program, or when I left, we had the largest testing program for genetic COPD in the state of Texas. We've believed in it. We started to be able to treat our patients and identify patients that we could actually help out with some sort of therapy. And that's what we're going to talk about today, and that condition is Alpha1 antitrypsin deficiency, okay? And pardon me, I'm a mover. So if I'm out of frame, hopefully you can still hear me out there, and I'll come back in frame. So this COPD condition called Alpha1 antitrypsin is what the topic will be today. I encourage you can interrupt me at any point, at any time. Ask me any questions. I'll answer them to the best of my ability. If I don't know what they are, I'll try to get you the answer and get it to the CME office. Or you can give me your email address and I'll email you this. So we all know COPD is a devastating disease, 3rd leading cause of death in the US. Morbidity, mortality is dramatically increased worldwide with COPD. Cigarette smoking certainly is the most prominent thing that we think of when we talk to patients about COPD. It's actually a spectrum of obstructive lung diseases, You have emphysema on one end, and you have asthma on the other. Asthma is reversible. COPD is non-reversible obstruction. Chronic bronchitis. Who knows the definition of chronic bronchitis? Nurses. You know, chronic cough, more than a few months out of the year, more than 2 years in a consecutive order, and that's how you basically can identify chronic bronchitis in those patients. And they'll flare up from time to time. You have to treat them a little bit more aggressively. Excessive mucus, hypertrophy of the mucus glands causing that excess mucus, inflammatory state, and usually you'll start to develop some scarring and some bronchiectasis and other signs on imaging that you can pick up during your exams in the office, in the hospital, acute stay. Electron microscopy is helpful when we're looking at lungs. This is slices, high-res CT scans when you're looking for interstitial lung disease, specifically when you're looking for more bronchiectatic pattern or chronic bronchitis. Certainly in the severe emphysematous patients, a routine CT scan or chest x-ray, flattened hemidiaphragms on your chest x-ray, and then you'll have the pan-acinar or central lobular emphysema identified on your CT scan that you can better identify if this patient, particularly in a patient, let's say, who's never smoked a cigarette in their life, and they have severe emphysema. What's one question you probably will ask? Let's say they're a young kid, 24, 25. What would you ask them if they tell you they've never smoked their whole life and they have emphysema?
Do they vape?
Oh yeah, vape, yeah, well, that's a whole nother topic. Yeah, secondhand smoke, you know. I have a lot of patients in our office, in our practice, that wind up, they grew up with their mom and dad didn't know, and they're smoking in the car, the windows are up, taking them to school every day, grammar school, high school, and they develop emphysema or asthma, and is really secondary to the exposure that they had at home from their parents. Most of the time, most patients are a little much better off. The parents who do smoke have either tried to stop if they have young kids, or they don't smoke in the car. I would love to do a study on kids who've developed emphysema who've not smoked, and parents who drove their kids to school, because I think there's a strong correlation to that. Any questions so far? We'll move along pretty quick. I know you guys are busy and want to eat. The food is very good, by the way. Mashed potatoes are fantastic. So smoking cessation or COPD risk factors. So some of this stuff is pretty basic. We're going to get into a little more detail about Alpha1. I'm just kind of reviewing the overall principles. Your handout and the slides in your handout are a little bit different. That presentation was I've given that before too. All the same information is in here with a little bit better graphics now. That presentation is from 1983, 84 timeframe. I don't think it's been updated, so this is a 2019 update. So you're getting state of the art. Risk factors for COPD, obviously smoking. Back where I'm from in the Tennessee foothills, we have a huge mining community. The mines aren't active anymore, but the generation of miners who would go into the coal mines, smoke, they both have black lung disease and they have bad emphysema. There's also, who knows or is familiar with cast iron cookware. So there's a big factory there in Tennessee in our community. And there's a lot of inhalation injury from chronic damage from the manufacturing process. Genetic factors certainly is what we're going to try to talk about and focus on today. There's a whole set of neonatal and embryonic growth development patterns. Asthma, age, certainly as you get older, you lose lung function just by getting older, about 10 cc's a year. Chronic respiratory infections, Mycobacterium avium is a big one that will blossom and cause COPD, or you have an obstructive pattern. And then there's association with socioeconomic status as well on patients who just don't have access to care. And I'm not sure how big, this is a huge hospital. I'm quite impressed with it. I was walking around. How big is your population out here for this? What's, anyone? 362 beds? Wow. Well, yeah, great entryway for, I mean, good cafeteria it looks like too. So it's a pretty big hospital for 362. And then there's a physician, I mean, the road coming in here, the long road to get up in here, was The land must have been free or something when they built it. So when we talk about COPD and alpha-1, so alpha-1 is a protein that helps protect your lungs, basically. Protein that's made in the liver. And it goes to help clean up bad things that are in the lung or protect the lung. And we're going to talk more about that. So when you have patients that are alpha-1 patients, you'll hear some myths of people who say, well, all COPD, especially emphysema, is always caused by smoking. Well, hopefully, but when you walk out of here, if you held on to that myth, you'll know that that's not necessarily true. I know an alpha-1 patient when I see one. So I go and I speak to a lot of groups, physicians, nurse extenders, other providers worldwide. And I've run across many folks in small areas and foreign places that say, oh, I only test a certain group of people because I can tell when they come in that they might have alpha-1. So it's a genetic condition. You can't tell by just looking at someone if you have alpha-1. So there's some test kits. I don't think I brought any, but they might be available that you'll have available. I encourage everyone to test themselves if you haven't already done that for genetic markers. It's a quick little dry blood spot test. And there's no better way to beat this myth than to identify yourself as a carrier or with severe disease. And you'll be surprised how many carriers are out there that you don't realize. And that generates a whole conversation to talk to your mom or dad, because someone passed that on to you, that gene. And then it's certainly helpful if you have children too. You want to know what their risks are down the road. Alpha-1 is so rare that I don't even need to test my patients. Well, I'm here today to tell you it's not that rare. And I want you to test and think about it when you're working in the hospital or working in the offices as a possibility for someone who has COPD. There is no need to test a smoker for alpha-1. Well, that is not true. In fact, we like testing patients who are smokers, all smokers, because it helps encourage them if they do get identified as someone who is at genetic risk or deficiency, their chance of cigarette cessation is much higher. Of course, in our hospital, who here does smoking cessation? Anyone? Raise their hands in their offices. So last year we implemented a smoking encouragement program. We don't have much in the way of smoking cessation anymore. If you pay your copay, show up on time for your appointment, you get a token. And on the way out, we have the old pool vendor machine with Marlboros in there, so they get a token, they can pull, and they get a free pack of cigarettes on the way out. We've never had any more missed appointments or copays, so it's very effective. I'm only kidding. With some serious people are like, that's a great idea. Can we get away with that? You can get away with that when you're in private practice. Your hospitals don't allow that. No. So I know if we ever implemented a program like that, we would probably be the largest practice in the whole Southeast. It's very hard to get people to stop smoking is the point. Sometimes my best referring sources are other pulmonologists who get on a soapbox and the patients get so upset that they just don't go back to that other provider anymore and want to go somewhere else. So we try to balance it with, well, we're not going to talk about smoking cessation today. Let's just work on getting your PFT a little bit better, working on exercise. It's a struggle, but when you identify someone with a genetic risk for developing COPD, particularly in young kids who are exposed to vaping or exposed to cigarette smoking, it may encourage them not to do it. I used to be a big supporter of vaping about 5 years ago, but now all these vape shops have come up. Have anyone been to a vape shop? So vape shops are pretty interesting. You need to go in and check them out. First of all, they're all ready and lined up. Once medical marijuana or recreational marijuana is legal, those vape shops will all be vape/marijuana shops. But the canister on a vape is, you're supposed to have 0.7 nanograms of nicotine, and then it's 0.5, 3, and 0. So you go from like a high dose of nicotine to medium to low to nothing, and you just have the habit of vaping water. So vaping is very effective for a smoking cessation, or replacing one habit with another and then wean you down off the nicotine. However, you can now go in, just like cigarettes, and say, hey, listen, I would like, I want a little more flavor in my nicotine cartridge. Okay, sure, we'll add a little menthol to it. And you know, it's a little bitter tasting for me and kind of burns my tongue. Well, we'll add a little bit of, how about just some ethanol, we'll do a little touch of formaldehyde. Now all of a sudden those cartridges have about 20 to 30 new chemicals in it, not just nicotine, just like how we started to with cigarettes. Say, you know, the science of a cigarette is pretty fascinating. You know, that glow on the orange, the tip of the cigarette, that is done by chemicals. The burn rate, that also is because it's soaked in a type of chemical that allows it to burn slowly. The type of paper is designed to be able to burn just perfectly, so there's a nice little brown edge around it and evenly burn in a perfect circle, not uneven. All those things are chemicals, the modern day of chemistry, that makes the cigarette perfect. So we're doing the same thing now for e-cigarettes. And that interaction of those chemicals, the burning, the heat, the tobacco, and the nicotine, you know, we don't know that, but that combination of everything is part and parcel with why you can develop cancer. It's not just the nicotine alone. The nicotine is the addictive side of the part of it, but it's all the chemicals that you're inhaling and you're just putting them in your lungs, and we don't know what happens. So we want to test for alpha-1. When we're looking at laboratory tests, we can confirm the presence of alpha-1. Serum levels, which we'll talk about, can miss up to 90% of carriers. So we also want to look at what we call phenotypes and genotypes, genetic markers of the actual disease process itself. And this is all done on this test kit that we'll show you and talk about a little bit. Once I identify an alpha-1 patient, there is specific treatment. We have about 4 or 5 different therapies that are very effective, and you'll be surprised how well some of these patients respond to therapy if you identify a severely deficient individual with genetic COPD. Any questions so far? About 24 million adults have airway obstruction, emphysema, chronic bronchitis. It's potentially a fatal form of COPD with alpha-1. If you don't treat it, they can get their lung function decline worse and worse every time they get an infection. They have decline in lung function to the point where I've had several alpha patients of ours that we've sent to lung transplant, Birmingham and Duke. And oftentimes if they're so old they don't qualify for it, then they just are now below that threshold where they're 20% FE1. I have one patient who just recently died who got down to 13% FEV1, and I'm surprised he lived as long as he did. So about 3% of all COPD cases is what we suspect are alpha patients in the COPD population. We need to test more frequently for alpha-1 in your office, in the hospital. And I'll tell you kind of my protocol and what to do quickly if you're in the hospital, how to identify a genetic COPD patient. So these are all symptoms, and I've talked about this many times with a lot of providers. You say, oh, well, I have shortness of breath, I get wheezing, I have dyspnea, I cough all the time, I have excessive sputum. Okay, if that patient shows up to your office, do you think about alpha-1? No, almost everyone has this. Allergy season, whenever, you just, okay, you have allergies. Oh, you're smoking cigarettes, you probably have COPD. Or you got a little bronchitis, we'll treat you. You should also realize you can't just diagnose genetic COPD by the symptoms alone. If you're going to put someone on an inhaler or you're going to put someone on an antibiotic because you think they have chronic bronchitis, you should always in the back of the mind or a poster on your board somewhere think about or have an index of suspicion. Hey, have I ever tested this patient for alpha-1 disease, alpha-1 condition? It's a simple, free test. Who here has kits in their office? Anyone? Who here has ever heard of alpha-1 before today? Okay, good. Whew. So, you know, up in Tennessee, in the foothills up there, you know, we have a lot of alpha cases, you know, because the family tree is basically one stick. And so there's a lot of genetic, there's not a lot of genetic diversity in some areas. So, you know, this whole Appalachian region tends to have a high rate of alpha disease. So you have to have a high index of suspicion to test for it. We kind of talked about this 3% contribution to COPD cases. It's made in the liver, and we're going to talk about the genotype and the phenotype. And there's certain markers. God gives you the beautiful ability of giving you two genes that make up the alpha protein. One gene, the normal gene, is called M, and that is made in the liver, gets released from the liver, no problem. Another gene is called the Z gene, and that's abnormal. And even though it makes some in the liver, it can't get out of the liver. So when it folds, this little protein here, molecule, it folds improperly, and it gets trapped in the liver. And you'll see some patients that will initially present with mild elevation in their liver patterns, their liver enzymes. And young kids, particularly neonates who have severe alpha deficiencies and disease, will sometimes present with jaundice and liver failure at birth. So you should also think about these adult patients with cirrhosis or things, abnormal liver function testing, of doing an alpha test on them. You don't need to do a liver biopsy for alpha disease, although part of that workup for your GI doctor may be looking at a liver biopsy for different reasons. And then we also know that there's a high correlation with people with alpha-1 severe deficiency developing liver carcinoma as well. So in those patients, you want to think about testing. So in the hospital, we have the free test kits that you can use anywhere. You can bring a package into the hospital and use it. But I'll usually recognize if I have a sick patient who has pneumonia, let's say, or has sepsis in the ICU, and I'll screen for alpha-1 antitrypsin deficiency on this patient by just doing what's called a serum marker or serum level. I don't get the genotype, the genetic markers, that M or that Z, because it's an acute phase reactant. So you and I, if we get sick and we're normal, and I check a serum level on you, your serum level should be greater than 90 normally, and you're very, very sick, I would expect that level to be 150, even higher than what a normal patient should be, because your body ramps up for this immune response. And if I test it and you're sick and it comes back less than 90, let's say it's 40, well, I'll say, well, now there's something definitely probably abnormal here because they're not having an appropriate response to their illness as an acute phase reactant. And that may prompt me then to get the genetic marker tester in the hospital. In the hospital, it's easy to get a serum level, comes back the next day, but the genotyping, the genetic markers themselves will take a little bit longer. Any questions? Any ICU staff in here? How big is your ICU here in this hospital?
46 beds.
46? Man, you guys are all the way out here. I was like, this is driving out here. 46 beds. We got 24 beds in our ICU. And how many surgical? I mean, you do CT surgery here as well?
We do. We have an 8-bed CT surgery.
8-bed CT surgery. Yeah, okay. So we have a 12-bed CT. That's pretty impressive. I'm going to check things out before I go. Maybe I'll move down here. So I'm going to show you a little bit what I call alpha-1 is kind of like the garbage truck of the lungs. So when you have an immune response, you develop all these neutrophil elastases. Your body ramps up, you get a viral infection, you get bacteria, and it sends all this stuff into your lungs. And if it's tracking down a virus, you know, these elastases, and I simplify this because I don't know the spectrum of the audience here, but the elastases go in and they chemotactic towards the bacterioviral, and they drill holes in it and kill the virus, and then it kind of dies and sheds itself off and fills up in the alveolar sacs, and you get pus and all this debris. So the alpha-1 antitrypsin goes around and helps clean up all that stuff and get rid of it and start to discard it. And it also helps to inactivate the neutrophil elastases. When the infection's gone and things are slowing down, it says, all right, it's time for you guys to stop killing and on a seek and destroy mission. And in the absence of it, these neutrophil elastases will continue to interact with your lungs, seeking out to try to destroy something. So we always want to have a nice normal balance between neutrophil elastase and alpha-1. And when we don't have this normal balance, we have this check and balance that's no longer present. And then you start to develop mostly a basilar emphysema, or you start to have these elastases start to actually destroy the alveolar sacs themselves. You add cigarette smoking onto that, you do all these other things that just then accelerates things. So I have a little video where I'm going to show you, hopefully the sound system works here better to talk. It's a very nice video. I hardly ever get the chance to show it. And so I'm excited to present it to you today. Let's see if it works. Hang on.
Alpha1 Antitrypsin, or AAT deficiency, is a genetic condition that can cause serious health problems, especially in the lungs. In fact, in one study, emphysema caused the deaths of 72% of people with severe AAT deficiency. It is the most prevalent, potentially fatal genetic defect among Caucasians. Genetic screening is the only definitive diagnostic test for AAT deficiency. AAT deficiency is a genetic disorder. The severity of AAT deficiency depends on whether or not the person has one or two copies of the defective gene. Of the common abnormal AAT genotypes, the severest form is homozygous for the Z allele. People with the PiZZ genotype only have 15% of the normal amount of AAT in circulation, making them more likely to develop emphysema at a young age. AAT serves a vital function in the lungs, where it protects lung structures from breakdown by neutrophil elastase. When lungs are injured, infected, inflamed, or damaged by cigarette smoke, neutrophils release elastase in response. Elastase is an enzyme that helps destroy bacteria and damaged host tissue. AAT is a protease inhibitor produced by glycan, released in the lungs in response to elastase, keeping the immune reaction in check. Normal levels of AAT in the lungs mean that neutrophil elastase only breaks down unhealthy tissue. However, when the liver does not produce enough AAT, elastase can attack healthy tissue. Elastase breaks down elastin, a key protein in connective tissue. This leads to chronic tissue breakdown in the lungs and ultimately emphysema. Cigarette smoking is particularly dangerous for people with AAT deficiency because smoke increases the inflammatory response, which causes the body to release more neutrophil elastase. Remember that you cannot tell whether a patient has AAT deficiency just by history or physical exam. There are several ways to diagnose genetic AAT deficiency, including genotyping and phenotyping. ATS-ERS guidelines support targeted genetic testing for both symptomatic and asymptomatic COPD patients, including all adults with symptomatic COPD or emphysema regardless of smoking history, all adults with symptomatic asthma whose airflow obstruction is incompletely reversible after bronchodilator therapy, asymptomatic patients with persistent obstruction on pulmonary function tests with identifiable risk factors, siblings of individuals with PiZZ. ATS also recommends diagnostic testing for all patients with unexplained liver disease and adults with necrotizing paniculitis. These tests are available from commercial laboratories and free test kits from Grifols. AAT deficiency is a serious chronic health problem. Up to 3% of COPD patients in the U.S. have AAT deficiency. Only 5% of patients with AAT deficiency have been diagnosed.
Now we'll go back. Without my glasses on, I did it. So we talked about this balance that we want to get back in place. We realized that, I like that video, it kind of sums up everything very nicely with much better graphics than I can ever produce. So our job is basically when we see these patients, this subset of liver patients, this subset of COPD patients who have some sort of obstructive disease, and we may not totally understand why they may have it. You want to have this high index of suspicion to be able to test for them. If you have patients, and I forgot to mention it, the video does a good job of this, necrotizing, paniculitis infection, fat infection, cellulitis infection of your belly folds, and you see a patient like that in your ICU or in your beds, and it's kind of refractory, doesn't seem to want to go away, you may want to think about testing liver function as well as getting an Alpha1 test, because you'll be surprised how many of these patients reveal themselves in other ways. The other thing in our support group, which I never knew, and I see a lot of it, is, and I forget what the technical name is, there's a name for it, where your skin on your finger pads gets very dry and peels off. Like just very fine, almost like you had a little sunburn on your fingertips, and they constantly are picking at dead skin that peels off on their pads of their fingers. I never knew this, but apparently in the alpha community, this is a very well-known condition of patients who have Alpha1 antitrypsin deficiency. And so I always see these patients when they're picking at their hands and, you know, look for clubbing, and you look and you see that they have peeling fingers all the time. I ask them, oh, is that something new? And they oftentimes say, oh, I've had this my whole life. No one can figure out what it is. I said, well, you know what? Let me do an Alpha1 test on you. I've yet to find one that's actually positive when I do that, but of the known alphas in our community, they talk to me about that all the time. Hey, do you know what causes that? And I really don't. There is a medical name for it, and I forget off the top of my head what it is. So Alpha1 lung diseases present with the common respiratory symptoms, which we kind of talked about in that one highlighted slide. You think about these patients when you see these conditions. We have criteria and guidelines, which the slide talked about, of when you want to test a patient. We're all so busy that for me, I'm going to give you the easy workflow on when you should think about testing someone for genetic COPD. If someone comes to your office or you're discharging them from the hospital and they've never been on an inhaler of any kind, and you're going to put them on an inhaler, whether that could be ProAir or any rescue inhaler, and it's the first time they've ever been on it, you should test them. Anyone who comes to my office or comes in the hospital and is on breathing medicines of any kind, you need to ask them, have you ever been tested for Alpha1? And they say no, you test them. That covers almost every single ATS ERS guideline, and a simple way for you to remember it. Because we used to put up a little pamphlet on the door for our MAs, and they'd walk out and say, okay, did this, 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 this. And it just slows the process down because we're just moving patients in and out so quickly. You just now say, okay, if I walk out of there and I'm putting them on an inhaler, you just test them. An even easier protocol, which we highlighted towards the end here, is a patient that, any patient in the hospital or in our offices that goes to the PFT lab or is getting spirometry done for any reason, you should just test them for alpha. And that captures every patient that has some sort of breathing problem. Even if you're doing them for surgical clearance and just doing a bedside spirometry, your respiratory tech should have kits there and just say, hey, part of our protocol to test is a dry blood spot finger prick test, part of the whole cart that they have on there to do the spirometry. And then the only part of the protocol that's sometimes hard to figure out is who do those results go to. It's usually whoever your respiratory director is for your pulmonary function lab. And then the follow-up. So liver cirrhosis, neonatal hepatitis, I mentioned about this severe condition. Usually these kids don't survive. We know there's an increased risk for carcinoma. The necrotizing pancreatitis, you identified in the hospital, you want to go ahead and have a high index suspicion again for testing these patients. We talked about the normal versus abnormal lung parenchyma and what emphysema looks like in a patient with Alpha1 or any COPD patient really. So when you have this pattern of a basilar predominant pan-acinar emphysema, upper lobe predominant, or bronchiectasis, these are all things that you're going to think about of patients that we need to do some sort of testing, along with all the other etiologies of bronchiectasis, which has about 100 different causes and reasons. Usually these patients are going to get some sort of bronchoscopy at some point to evaluate their BIL washings, particularly if I'm trying to identify a mycobacterium infection. We talked about how bad cigarette smoking is and how if you identify someone with a genetic condition, you have a real opportunity to get them to stop smoking. And we know the whole cascade of cigarette smoking is a vicious cycle of all the contaminants in it, causes this oxidative stress, which then triggers a whole bunch of inflammatory patterns, and you increase your mucociliary cells, and you increase mucus, and then you have this chronic pattern of persistent oxidative stress, and then epithelial injury and inflammation, and then there's just chronic injury over time, breaking down the alveolar sacs, chronic emphysema, and then chronic bronchitis and recurrent infections on oxygen. Basically, they get to the point where they're respiratory cripples. So you really want to encourage the smoking cessation. When we talk about, when we talk about the decline in lung function, so our goal is basically in these patients, we want to try to prevent losing any additional lung function. Usually by the time they're coming into you, they're not normal people. They're not still 100% FEV1. There's something less than normal. So you can see if we can get them off cigarettes, we start to slow the decline in their FEV1 versus people who are still current smokers. Our goal is to preserve lung function. If anything you take away from this is you want to preserve lung function. You want these patients to be able to still breathe and have a normal quality of life without crossing the threshold. You know what the magic number is for FEV1, how forceful you can expire air in 1 second, where we kind of say this is where you're going to need oxygen and you're almost a respiratory cripple. 30% FEV1. So there's a famous slide in New England Journal from 1972, talks about, and you may have seen it, where it talks about in a normal, healthy person, if this is their FEV1 on this axis, and on this axis is their lifespan, and we say this is 0, and this is 100. This is 100 up here. So a normal, healthy person, as they get older, they have a slow decline, but it never really crosses or gets less than 80% FEV1. It's imperceptible to a person greater than 80 years old. When you smoke cigarettes, though, even if you smoke a half a pack a day or 1 pack a day, everyone starts off at 100, but you have this rate of decline that's much faster on the smoker. And that slope is what we want to try to change. And then over here is a number called 30% FEV1. Once you cross that number, that usually means you're at the point of no return and you're going to need oxygen, more than likely. There's several patients that don't have oxygen, or they can't do the normal things like walk to the mailbox or push the grocery cart down the aisle to go shopping. They have to sit in the little cart, the motorized scooter. So those are the things we want to try to help these patients not cross that threshold by identifying who can be a candidate for smoking cessation or who is an Alpha-1 patient that could be a candidate for additional therapies. The lung cancer risk goes kind of without saying it. There is an association between lung cancer and mycobacterium infections and pulmonary embolisms with patients with Alpha-1 disease, although that's not well published. Currently we're doing a study on pulmonary embolism associated with patients with severe alpha disease ZZ states. So we talked about the normal genotype patients versus the ones that aren't normal. There's an increased risk of lung cancer in patients who are heterozygotes. So it's interesting, some people here probably have never even heard of Alpha-1. Everyone probably has heard about idiopathic fibrosis and cystic fibrosis. But if you look at the prevalence of the disease for Alpha-1, we're actually more prevalent than cystic fibrosis. Cystic fibrosis is very good. They get a great foundation. So does the Alpha. We have a great foundation. That's why I'm here today. It's from sponsored by the Alpha-1 Foundation. But they also are very politically active. We're very politically active. Most of the time we identify people, for us, are adults. Cystic fibrosis is usually kids, so there's a little more emotional interest there, and they seem to get a lot of attention, rightfully so. But I'm here to tell you that alpha is up there at very high prevalence, and we need to be testing more for it and looking for it in our patients to help them out. So Kentucky, not too far away from here. A colleague of mine, Dr. Kawari, I just had dinner with him not too long ago, and he was private practice, and now he's working in the hospital. He's moving towards that retirement, just taking a little bit a better lifestyle. And he did this huge study in his practice to identify patients that never been tested before, and what was, how often did he identify people. And so he really did find, out of the number of patients he tested, severely deficient patients that could benefit from therapy. He found a whole bunch of different carriers, and then a whole bunch of more severely deficient here. So he offered therapy. He made a real difference in these people's lives, and offered a whole bunch of genetic counseling to the rest of the group, which had an impact on the families of those patients that were carriers. And we can also look at the lifespans on severely deficient patients. We talk about ZZ as being severely deficient. If you have, compared to the total US population, your lifespan should be pretty good, but patients who are severely deficient and never get treatment have a less than happy lifespan. So it's shortened. So we want to be, and there's various reasons for this. Basically, the survival curve is based upon the number of infections they get, failure to diagnose it over time. And you can see from the data in the registry that we maintain that on average, it takes about 3 years for a correct diagnosis to be made. Between the symptoms, the years between the symptom onset and the diagnosis, about 8 years. And on average, you're about 46 years old, 50 years old before you get diagnosed. So we really want to try to shift these numbers to, 1 year, one doctor, 1 year, and as early as possible, in your teens ideally, to get diagnosed. So then you can have impact on them when they're talking about smoking cessation. I keep hitting on smoking cessation because it's so important to identify patients that are a genetic risk, and we know that the tobacco cigarette will accelerate their decline. And when you explain it to them that way after 2 or 3 visits in a dedicated smoking cessation program, not unlike our smoking encouragement program, you'll make a real effort on these patients getting off cigarettes. About 25% will stop smoking. This is the formal guidelines, and I told you, remember, anyone who you put on an inhaler, regardless of smoking history, generally that means they've got symptomatic COPD or symptomatic emphysema. Any patient that has airflow obstruction that's not totally reversible, COPD, so I'm putting them on an inhaler. These are all people you're going to test. And then any asymptomatic patient that has persistent airflow obstruction on their PFTs, again, probably going to be putting them on some sort of trial of inhaler. You test them. And then this one here is any family members that you identify with alpha should be tested. That's the genetic component of genetic counseling. Kind of just wrap up in the next 5-10 minutes here, talking about indicators of your patients with COPD, kind of frequent exacerbations. You don't know why they keep getting sick. More often than not, they come in. You just keep giving them an antibiotic and an inhaler and a steroid pack. They come back next month, they're sick again. An antibiotic, inhaler, steroid pack. At some point, you need to think about maybe something else. Bronch them, send them to a pulmonologist, or do an alpha test. Try to identify these recurrent patients so that you can protect. Again, our job is to prevent further decline in lung function. Every time a patient with Alpha1 or COPD just from cigarette smoking gets sick, they lose a little lung function. They never get it back up to the level they were before. And that gets you closer and closer to that 30% FEV1 number, which is what we want to avoid. So this is a nice scatter plot just talking about Alpha1 in patients with ZZ, a nice little study. And if we said, I have had a group of physicians that say, hey, listen, you need to test all patients. Oh, no. We only test patients between the ages of 35 and 50 really who are smokers. Okay, now these are severely deficient people, ZZs, those 2 genes. So the way you think of ZZ, you make 0 protein, Z and Z. Okay, they have no protection on lung function. But we're only going to test between 35 and 50-year-olds who smoke. All right, and they're below this threshold line of 30%, severe COPD. These are people we need to help. We can offer them something, quite a few. But if you broaden your horizon just a little bit, and let's just say we're going to test all people who smoke, look how many more people are positive. These are all severely deficient. Even this one up here, normal, this group here, normal FEV1s. But we don't know if they're moms or dads, how many kids they have. Maybe they're still smoking. Maybe they're working in an environment they need to get out of before they decline. So you can have an impact on these people's lives. Now let's say we say, well, I'm going to test all non-smokers. Well, now look how many more people you're missing if you just keep yourself in this box and say, I'm going to just test, young people with severe COPD. You miss a whole bunch of people. And so that's why I encourage you to go out and really change your pattern of thinking, change your practice habit or your practice pattern, and test more frequently, or become the champion for this hospital. And then, you get your name on the board, they name a building after you, something as, I remember that person, he did all that testing for Alpha1, and now, you're the Alpha1 leaders in the state. They didn't name a building after me at the VA because Dr. DeBakey was a lot more famous. So. Average age of years when we test, 53% of the people are detected or identified as ZZ after the age of 50. And that is what we really want to shift that over to this side if we can. When we talk about these genotypes and the serum levels, I mentioned to you that there's two numbers, micromoles and milligrams per deciliter. They're converted here equally. But basically, when we say micromoles, anything under basically 11, we're going to say severely deficient, or under 90. So that line there. Normal, you make more protein, you make more protein. Okay, now this doesn't mean when you go out there and talk to some professor in University of Alabama, and he says to you, well, that's not what the M really stands for. I agree. I'm just way for you to remember this. So it's gel electrophoresis. The pattern on those gels, electrophoresis plates, in the old days we labeled them as M or Z, and that's how we came up with those letters. But the M makes more protein, makes more protein. S, you make some protein. MS, you make more in some, so you got enough protection. Z, you make zero protein. Now that's not totally true. You actually make some protein and just can't get out of the liver. Okay, and the liver gets clogged up with it. So you have M and a Z, so you make more protein, you make zero protein, you're deficient, you're a carrier. The ones we really worry about are the orange and reds, where you say SZ or ZZ. You make zero protein, you make some protein, or you make nothing at all. And these patients need some sort of protection if you have a CT scan that shows emphysema and they have a declining lung function. With the FEV1 going down and the DLCO dropping, you want to start thinking about therapy for these patients. We kind of talked about the serum level alone. So if you're very, very sick and you say, okay, I'm going to get a level on you, and it comes back as 90, right on the borderline, you may say, okay, that's a normal number. Well, it's really not. They should be higher, so that's when you want to go do this genotyping and phenotyping. Phenotyping is an easy way for us to get a quick analysis of whether you're an M or Z, and then the genotyping is really actually taking the blood, a vial of blood, and actually extracting the DNA and doing a DNA analysis on the deficiencies and identifying which, confirming that this really are the genes that are missing. Another way to think about phenotype and genotype is, our DNA is essentially all the same. Your eye color may be brown, mine may be blue, and that little variation is the phenotype between the two of us. And we can identify specifically why, what am I missing that caused me not to have brown eyes or vice versa. So it's just a higher level of testing, which has to be done for us to be able to more effectively treat these patients. So this is the dry blood spot test kit. Currently it's made by Genetics. It's a free test kit. It's the only free one now. I think the others are pretty much either not being made, or they bill the patient for it. The company Grifols now offers that as a confidential free test kit. They don't get any information. It's just that they sponsor Genetics to offer it for free. So it's a really nice way to get something to your patients that's easy, simple to use, and test these patients. It's CLIA certified or CLIA waived, so you can do it in your office anywhere, and you just put it in the envelope and you put it in US mail. Simple and easy to use. And then you can track the results by going to the website myalphakit.com, and you'll get a report back as well. Whoever you put down as your physician to track it, they'll get a fax report showing you something very similar to this, where you have the bars like I just showed you on that one slide, tells you what your genotype is, SZ or FI, which are some rare alleles. and then talks about what your serum levels is and gives you some information. And then you can always call the company that does this, the genetics, and talk to this gentleman here who actually developed the DNA testing for Alpha1, who's also a brilliant individual, has been doing this for a long time, and I've had the opportunity to meet him and talk to him as well. And then the Alpha1 Foundation has a great support, and you can reach out to them website and ask for more information if you identify patients, or you give it to your patients, information about smoking cessation, what are my options, where do I go to treatment centers. And then I kind of beat the whole smoking thing with a stick, like a stick, a dead horse with a stick. Finally, I just want to end with this powerful slide. This is a family, a real life family of ours that I had the opportunity to work with. So this is their family tree, and when we're talking about genetic testing, we have a patient comes in having some symptoms and breathing problems. We test them and we find out this patient is an MZ. So this is the index case right here. And so this is his family tree. And we go up here and say, well, can we identify what your grandfather and grandmother were? Yes, we can. The granddad was an MZ and mom was a ZZ, severely deficient. Just so happened to marry a carrier, as luck would have it, probably from the Appalachian area. So then they have some offspring and they have a son who has a ZZ, so picked up one gene from dad, one gene from mom, ZZ. Marry someone that weren't able to identify, but they had two offsprings, and all these offsprings are carriers. What is interesting when you look at this way, I'm getting old, so I have to look at my glasses. You can see that the patient on the right here, the ZZ, he died of liver disease, and mom and dad both died pretty early ages up above here. So now we're starting to go down this tree and go, well, look, they had another son, he's a carrier, and he marries someone who's also a carrier, and then they have a daughter who's a carrier. You're like, wow, this is a really, all from one patient that we identified. And we start tracking the family and identifying these people to say, hey, listen, this one who's still smoking, counseled, she's no longer smoking. Okay, because she never knew she was a carrier. Come over here, had another son, ZZ, marries. I don't know what it is about alphas, but alphas have a unique ability to seek out other alphas and marry them. It's another study I'd love to do, because it just seems perplexing to me that there's all these alphas out there and they all marry each other. So severely diseased, marry someone who's diseased, and this is really unfortunate because all three of their offspring severely deficient. One dies at an early age, liver failure after liver transplant. One died age 2, and one, and this is that phenotype, it's that penetrance, is doing fine. ZZ, normal lung function, normal everything right now. Just kind of not even on therapy, just watching and waiting, treat early aggressive interventions for infections, hospitalizations. We take care of them quickly, doing fine. So kind of perplexing why that one is doing so well. They have a daughter, MZ, marry someone we don't know who, and then wind up having a carrier state. The Z came from probably her, we don't know. And then when we look at our index case, so mom and dad was ZZ, normal, comes down, and marries a carrier, and all their children are carriers. So you can see the impact you can have on somebody's life if you're a primary care physician, you're a pulmonologist in the office. This whole family tree took a lot of time and effort to figure out, but we made an impact on a lot of people's lives, at least we felt we did, and made maybe some changes in behavior and patterns for them. And then smoking cessation, testing improved quit attempts. When you talk to them, you can kind of see the carriers versus people who are severely deficient, how quickly they stop smoking or make an attempt after the first 24 hours after counseling. Counsel, get them off cigarettes, pulmonary rehab, avoid becoming a coal miner, avoid working in a chemical plant around inhaled irritants. Make sure you get all your proper vaccinations, do all your proper pulmonary respiratory therapies, pulmonary rehab, and then, and then you can offer augmentation therapy, which is a once weekly infusion of 5 different types of medications that are available. We choose one of them, whichever best fits your needs and your insurance requirements. always get them approved. They're a little bit expensive, but we always get them approved once we identify you. What you sometimes hear, oh, I have a failed genetic disease. You have only 2 years to live. I've heard these things before. You better get your affairs in order. But the reality is we have great benefits. These people will live long, healthy lives if we identify them early, treat them early, and put them on better therapies, and just be aware. And they can get the big fat blue book that helps guides their Alpha1 management, we call it. Alpha1 Foundation will offer that. And these are the websites and opportunities that you can write down. I think it's on the last slide that you have too on your handout. Give resources for your patients and for you to look things up. So I apologize to the camera if I moved around too much, but that's it. Hopefully I kept it within an hour.